Hello everyone, my name is student Dr. Hannah Tully and I am a fourth year medical student on the Tulsa campus. I am representing myself and my colleagues, and the research project I will be presenting today is Clinical Manifestations of Meckel's Diverticulum, a case series. Meckel's diverticulum is the most common congenital abnormality of the gastrointestinal tract. Its pathophysiology stems from embryological origins in which the vitelline duct fails to obliterate during the 5th to 6 weeks of fetal development. Meckel's diverticulum is relatively uncommon and known for its rule of twos, affecting around 2% of the population in a 2-to-1 male to female ratio, 2 inches long, within 2 feet of the ileocecal valve, although there is some variation in these features. Meckel's diverticulum can be challenging to identify due to life-threatening complications that can occur leading to various presentations. Therefore, it is important to understand for clinicians to identify these. So our goal for this case series is to introduce 2 cases of complicated Meckel's diverticulum that we encountered at a pediatric hospital in Kathmandu, Nepal. Case 1 is an example of intestinal obstruction caused by Meckel's diverticulum. There was a 3-year-old female who presented with 3 days of fever, cough, non-bilious emesis, tachypnea, followed by 1 day of periumbilical abdominal pain. Vital signs were stable, and physical examination did not reveal any abnormalities. Lab findings were significant for a white blood cell count of 23,400. Abdominal ultrasound, chest x-ray, and CT abdomen pelvis were obtained, and all supported findings of multiple dilated bowel loops consistent with features of acute intestinal obstruction. The patient was subsequently taken to the OR for an exploratory laparotomy where findings revealed a volvulus with perforated Meckel's diverticulum and adjacent regions of necrotic bowel. Resection with anastomosis of the bowel was performed. Here are some radiographic images from case 1. Figure 1 is a chest x-ray that reveals the characteristic coffee bean sign with a volvulus. And figures 2 and 3 are CT scans from a transverse and frontal view that represent the dilated bowel loops and characteristic stair-stepping pattern indicative of a bowel obstruction. Case 2 is an example of Meckel's diverticulum causing intussusception in a 6-year-old male. This patient presented with 10 days of abdominal pain followed by 5 days of non-bilious vomiting. Vital signs were stable and physical exam did not reveal any abnormalities. Lab values were significant for a white cell count of 14,000, and abdominal ultrasound and CT abdomen pelvis were obtained, which showed dilated bowels and some concern for intussusception. This patient was taken to the OR for a wedge resection with an ileo-ileal anastomosis. And here are some radiographic images from case 2. Figures 4 and 5 are CT images that reveal some dilated and inflamed bowel. And figure 6 is an intraoperative image obtained in which we can clearly visualize the lead point from where one part of the bowel invaginates into the other. There are a number of complications that can arise from Meckel's diverticulum, and they can all present in various ways. This makes it important for healthcare providers to consider this diagnosis with presentations of nonspecific abdominal pain, especially in the pediatric population. There have been a number of studies highlighting the various complications that can arise from Meckel's diverticulum. One pediatric case series looked at 286 patient presentations and recorded 35% with rectal bleeding or melena, 20% with diverticulitis or perforation, 14% with obstruction, and 12% with intussusception. Radiologic imaging, such as ultrasound and CT abdomen pelvis, typically only reveal nonspecific findings such as dilated bowel loops. A definitive diagnosis of Meckel's diverticulum requires either a Meckel scan, mesenteric arteriography, or abdominal exploration. Of these, abdominal exploration is typically more common due to availability of resources and acuity of presentation necessitating emergent surgical treatment. Surgical approaches vary by country. While both of these patients had an open laparotomy in Nepal, the United States typically uses a laparoscopic approach. Interestingly, a retrospective review of the National Surgical Quality Improvement Pediatric Program database did not find any differences in operating time, postoperative complications, or readmission when comparing the 2 surgical approaches. These are our references. I appreciate your time and thank you for listening.